I just want to introduce our audience to Professor Jason Knight. Professor Jason Knight is a Marvin and Betty Danto Research Professor of Connective Tissue Research and Professor of Internal Medicine Division of Rheumatology, University of Michigan Medical School, Ann Arbor. Professor Knight is a physician scientist affiliated with the University of Michigan. He is an international expert. Expert meaning expert, and he's a leader in the care of APS patients and in the role of inflammation. He received his MD and PhD degrees from the University of Michigan, completed his molecular biology PhD at the University of Pennsylvania. His fellowship in rheumatology was at the University of Michigan, where he pursued postdoctoral research in the lab of Dr. Mariana Kaplan. During his fellowship, he received the prestigious American College of Rheumatology Distinguished Fellow Award, as well as the Rheumatology Research Foundation Scientist Development Award. And as a faculty member, he was awarded a Young Physician Scientist Award by the American Society of Clinical Investigation. He also was given a Vic and Kelly Braddon Memorial Grant for Lupus Research by the Arthritis National Research Foundation and an Edmund Dubois Award for the young researchers from the American College of Rheumatology. The goal of Dr. Knight's NIH-funded lab is to develop more effective therapies for thromboinflammatory diseases such as lupus and APS. And his studies have really shown he was the first to show the exaggerated role of netosis in APS, as he'll talk to us in a minute. And he has published more than 30 papers only on this topic. He's published more than 300 papers internationally. And of course, it's a great honor that he is with us. But of course, I cannot end his biography without giving a shout out to his favorite friend, Beagle. Beagle is the APS mascot. He's a beagle and he's called Sparky. And I really want to welcome you, Professor Knight, onto the stage, albeit virtually. And thank you for agreeing to be with us, and thank you for your time. Professor Knight, if you're with us. Okay.
Yeah, thank you. Do you hear me okay?
Go ahead. Can you hear us?
Yes, I hear you. Do you hear me?
He's muted. I hope you could have heard all this prestigious talk.
Yes, I heard the very nice introduction. Are you able to unmute me?
Yes, we can hear you loud and clear. Thank you very much. Go ahead. And welcome to Alexandria, albeit virtually. Thank you very much. And the Egyptian Society of Rheumatology, all the members, thank you for accepting to be with us. Thank you.
Yeah, thank you so much for inviting me. It's a real honor to be able to present here. And thanks for that very, very nice introduction. I don't know how much more I have to say. I have a short 20 minutes to speak to you, so I will only cover some high-level topics, but I hope there will be something in here that will be useful. And as we get going, so I have some disclosures, but none are directly relevant to what I'll be covering today. And here's what I'll try to do in this brief 20-minute talk. I'll start by talking about a case that unfortunately doesn't have a great conclusion, but I think still does a good job of showing us some of the unmet need we still see in the clinic. I'll briefly give my thoughts on the new classification criteria, relatively new, not as new as they were a couple of years ago. I'll talk about some treatment ideas, but really looking to the future. So these are things that you likely will not be using in your clinics right now, but perhaps in 5 and 10 years down the road. We'll return to the case to give some closing thoughts there, and then I'll give some closing thoughts overall. So let's start by getting into this case. So this is a 37-year-old woman who was referred to our clinics at Michigan for difficult to treat APS. And the case will probably seem a little complicated, but I did simplify it some to make it presentable. There's lots of other little aspects that we won't talk about. But her history went back to age 19. She was healthy at that time, but developed a DVT. She was on birth control pills at that time, and that was felt to be the likely trigger. And she was treated with 6 months of anticoagulation, as was common in that era. She did well for a decade, but then at age 31, she developed inflammatory joint pain, and that led to her seeing a rheumatologist. A lot of her lab testing was negative, but she did have strong positives for a couple of the antiphospholipid antibody tests, anticardiolipin IgG at a strong level, and was also lupus anticoagulant positive. She was started on hydroxychloroquine. It was felt that she might have a lupus spectrum diagnosis, as inflammatory arthritis was the main thing that brought her into the clinic. It was recognized that she had this history of a clot, but anticoagulation was actually deferred at that time. The feeling was it was a provoked clot. A decade had passed without any more issues, though she did begin taking a baby aspirin daily. 1 year later, at age 32, she presented with abdominal pain, which quickly progressed to multi-organ dysfunction. So now, a year later, after that rheumatology visit, things have gone quite severe quite quickly. She actually needed her right colon to be resected because of evidence of likely ischemia. And indeed, the pathology showed fibrin thrombi and submucosal venules. As that was happening, her kidney function was also deteriorating, and she required temporary dialysis support. She did get a kidney biopsy, which demonstrated evidence of thrombotic microangiopathy, so similar pathology to what was seen in the colon. And so she was diagnosed with presumed CAPS and was treated with the triple therapy of heparin, glucocorticoids, and plasma exchange. She recovered relatively well, although her kidney function did not go all the way back to normal. She was discharged with new prescriptions for warfarin and also was started on atorvastatin for some borderline high cholesterol. Hydroxychloroquine was continued. She did well for a few more years, or relatively well, when at age 37, she developed dyspnea. Chest imaging showed pulmonary infiltrates, and it was initially thought she might have an infection, but the infiltrates did not resolve with antibiotics. And so during an exacerbation, she was admitted to the hospital and was found to have a drop in her hemoglobin. And as you can probably guess, bronchoscopy was performed and showed evidence of diffuse alveolar hemorrhage. So we have a patient that started with a DVT, then presented with basically catastrophic APS. At that point, she was started on all the right treatments, and yet there's still evidence that her condition is progressing with now a flare of diffuse alveolar hemorrhage. So what do we do now? And that's what we'll come back to in about 10 minutes after we've gone through some other aspects of APS. So let me give you my thoughts on where we're at in terms of classifying APS. I'd like to start by reminding you what the 2006 classification criteria looked like. These criteria were not perfect, but did have some upsides, including their relative simplicity. So here's what those look like. A reminder, and this goes to the early days of the APS field in the 70s and 80s when it was recognized as a sometimes complication of lupus. Nowadays, we know that we can also make a diagnosis of primary APS, and that's actually a more common condition than APS complicating lupus, but it's important to be aware of both. We look for certain laboratory tests, and we'll see that these have not changed so much in the new classification criteria. These have been around for a while and persist. And then we look for relatively simple clinical presentations, a thrombotic event in any vascular bed, arterial, venous, or microvascular, and certain obstetric morbidities. Now, a downside of these criteria, they're simple, they're easy to teach to the med students, but both patients and doctors recognize that they failed to capture all the aspects of APS, including some of those that we saw in the case that we looked at. This is something I wrote about in 2023. This was just before the new classification criteria came out, but we were pointing out things like valve disease and alveolar hemorrhage, kidney disease that we can see in our APS patients that we were not always able to capture with the 2006 classification criteria. And so that led to these new criteria developed in 2023, a collaboration between ACR and EULAR that I had a peripheral role in. I was not a main driver of these, but I was able to help a little bit. We still look for this combination of clinical domains and laboratory domains, so that concept persists. We're going to look for points in each of those. And the clinical domains are more complicated and I think have a lot of good aspects to them. We have maintained both venous and arterial thrombosis as ways to classify someone as APS, but there's now a better emphasis in paying attention to other risk factors. We know that the so-called unprovoked clot is going to be more specific for APS than a clot that happens in the setting of many other risk factors. A lot of innovation here with much better definitions in this microvascular box with things like pulmonary hemorrhage and myocardial disease now being much more precisely defined what we mean when we attribute those to APS. So I think this domain is a very nice step forward. We do see some changes in the obstetric box here. Now recall that these are designed to be classification criteria for research purposes, and there was definitely an effort to push for specificity that was at a very high level. So we know in the clinic that recurrent early miscarriages can be an aspect of APS, and that's something I talk with my patients about and try to treat. Yet if we're classifying APS for research purposes, the specificity just wasn't felt to be there with those early losses just because they're already somewhat common in the general population. So we get the strongest points here for late pregnancy features, which we know are most specific for APS. Valve disease, it's nice to see attention shed on this. This is definitely something we see in the clinic, and I'm sure you do as well. And then thrombocytopenia. So now more diverse clinical presentations can be captured as APS. The lab domains look relatively similar to what we saw before. But one thing that was emphasized in the footnotes is that the testing details do matter. So if we look into these details, there's some interesting points. There is more of an emphasis, even than there were in the prior criteria, on trying to establish thresholds of antibody positivity. As we'll talk about in the next section, these antibodies are not just markers of disease, but actually drive pathogenesis. So it makes a lot of sense that higher levels of antibodies carry more risk. And so there's this effort to assign more precise numbers. But the problem is, and something you need to be aware of, is that the numbers that are quoted in the criteria here are really only focused on the ELISA testing that has been around the longest. In the US, now more than half of centers do not run ELISAs. They run some type of a high throughput testing platform in which the numbers are often read out quite differently. So I like to point out to people that you need to be aware of your local testing platform and not overinterpret numbers like 40 and 80 if they don't apply well there. There is an international effort to try to better align these numbers, although it is a daunting task given how many testing platforms are available around the world. Again, I have to emphasize to people to be aware of numbers like 40 and 80, but not overemphasize them if you run a different platform. So that was a high-level overview, and in my limited time here, I wanted to spend a minute talking about some futuristic treatment ideas. It was very nice that that recent review article was highlighted in the introduction there, and yeah, a lot of this is taken from that article. So first, to remind you about APS pathogenesis. So in my opinion, this is a proper antibody-mediated disease, not unlike something like myasthenia gravis that we see in the clinic, where antibodies are not just biomarkers, but clearly pathogenic. One thing these antibodies can do is activate neutrophils, and this is an area that my research lab has worked in now, I guess, for just beyond 10 years since we first described this. But an important thing to be aware of, it's not only neutrophils, there's also solid evidence that these antibodies can activate other cells like platelets, endothelial cells, monocytes, the complement system. And so as I've thought more and more about this, I worry that it's going to be challenging to find a single drug that combats all of these mechanisms. Of course, we like to think in my lab about like new ways we might be able to counteract the neutrophils, but is that going to be enough? Is that going to leave endothelial cells and platelets still unchecked? And so The common denominator here is the antibodies themselves. And I anticipate we're about to enter an era where modulating these antibodies is going to be more of a priority than it has been historically. Because indeed, historically, we have focused on drugs that I would argue are pretty far from that source. They are orbiting the source, but not really close. And even in challenging cases, when we need to bring immunomodulatory treatments, we typically do not see antibody levels change in these patients. It still feels like we are not getting all of the way to the heart of the condition. So what could a future look like? One area I'm keeping an eye on that's interesting, I think that we don't hear as much about in rheumatology as some other fields like neurology and hematology, is neonatal FC receptor blockers. So as you probably know, these neonatal FC receptors live in endothelial cells. Of course, they also live in the female reproductive system, and that's where their name came from, as the placenta manages the delivery of IgG to the neonate. But in this case, they also live in endothelial cells. It turns out our endothelial cells are eating our plasma proteins all the time. A lot of that protein gets degraded, but this special receptor grabs the antibodies and spits them back into the circulation. So antibodies have extra protection to extend their half-life because they are resistant, relatively resistant to degradation by endothelial cells. If we block that receptor, we lose the ability to spit the antibody back into circulation. It's now targeted for degradation. So this decreases circulating IgG levels by 50 to 80%. That's a level that may be acceptable for staving off infections, but in an autoimmune condition could be enough of a decrease to make a difference. This is an approved therapy in the US for myasthenia gravis, and there's very nice data in immune thrombocytopenia. That's another approval we may see soon, and it's also under investigation in some other antibody-mediated conditions. So keep an eye on this for the future of APS. So what about anti-CD38? So as rheumatologists, we're very familiar with anti-CD20 therapies, which we continue to have new versions of. But one thing to note about CD20 is it's missing from certain mature B cells in terms of short-lived plasmablasts and also long-lived plasma cells. They either express CD20 weakly or not at all, and they're not typically impacted by an anti-CD20 treatment. What these cells do have, though, is another marker called CD38, which is an ectoenzyme that regulates NAD metabolism, but also has been leveraged in the multiple myeloma field as a way to target, in that case, cancerous plasma cells. And so here is an active clinical trial we have underway. This is supported by the Immune Tolerance Network, which is a branch of the NIH. We're cautiously optimistic that that support is going to continue despite some challenging times here in the US. But this is a dose escalation study, as this is the first time a drug like daratumumab has been applied to an autoimmune condition systematically. So certainly we're assessing safety, and that's technically the primary outcome of the study, but a lot of attention is also being paid to what happens to the antiphospholipid antibody levels. And so we're going to learn if temporarily depleting plasma cells could be a more effective way to drop these APL than what we see with, for example, an anti-CD20 treatment. So look for hopefully results of this study reported out sometime next year. Now, a very hot topic that I'm sure has come up somewhere in your conference is CD19-based cellular therapies. There hasn't been nearly as much in APS as we have seen about lupus and scleroderma and some other conditions, but I still anticipate APS may be coming. Here was a short case report, one of the few examples I can find in the literature right now. This was a 65-year-old woman who had a history of APS, so that was in her past history, but she unfortunately went on to develop a lymphoma. It was a difficult to treat lymphoma requiring lots of different treatments, and eventually she went on to have a CAR T cell therapy. And so that was done in 2023 here. And so we have far from perfect data, but we do have evidence for positive antiphospholipid antibody testing in the years prior to the CAR T treatment. And then post-CAR T, there was not evidence that antibodies could still be detected. So we see a decline, a disappearance of the lupus anticoagulant effect, and a decline in anti-cardiolipin and beta 2 antibodies. So not perfect, but some hints of a potential benefit there. And then I think something else, a related topic that I'm sure you're also hearing about of bispecific T cell engagers, maybe bringing some of that same potency as cellular therapies, but potentially with less risks associated. And so, yeah, this is probably too simple for many of you, but the idea of these bispecifics is rather than relying on the FC region of the antibody to do the effector functions, we can directly reach out and grab a CD3 positive T cell. This may lead to more potent and effective killing. And so here the example is CD19, which is present on most B cells. This is something I still haven't seen in the APS space, but I anticipate companies with these drugs, APS is one of the indications they're going to be interested in. So again, these are not therapies you're going to be bringing to your clinic tomorrow, but I wanted you to be aware. I think it's something important to keep an eye on. So let's return to the case. I'll tell you briefly what happened, and then we'll give some closing thoughts about the future. So she had a bronchoscopy that demonstrated diffuse alveolar hemorrhage. So now what? This case played out a few years ago, and yeah, we still did what we've been doing for the last decade or so, which we treat patients like this with steroids, potentially rituximab. Mycophenolate could have been an option. Those are probably the two immune suppressants we use the most in these difficult patients. And she did do okay. So her lungs got better, but unfortunately, we've seen a slow deterioration in her kidney function. She remains on warfarin. She's gotten Rituxan, yet still her kidney function is worsening. And so it looks like she will soon need to start dialysis. And there's a question about whether she's too high risk to be listed for a kidney transplant or not. And that's something we're dealing with now. So here's a patient where we mostly did our best. There may have been an initial 10-year gap before a diagnosis was made, but it did not take long after that before the diagnosis came to light. And despite bringing all of our modern therapies, she has continued to worsen. So just not good enough. So some closing thoughts. And so this is a table, to encourage you to go check out this article that's online now in a nicely formatted form. I don't think it's appeared in the journal yet, presumably later this year. But here I was pointing out some of the unmet needs. If we are going to get to a future in which we can begin to think about combating the antibodies directly, like what things do we still need to learn? I mean, one thing that we did not touch on in any detail is the different isotypes. APS is, at least in my clinic, unique in terms of the testing I order typically gives me feedback about multiple isotypes of antibodies. That's not something I see in my lupus patients or Sjogren's patients. So it's something we need to understand better. We're confident the IgG antibodies are pathogenic because that's where most of the mechanistic work has focused. But we need to get smarter about IgM and IgA. If we get to a future where we think about stopping someone's anticoagulation, for example, if we're able to cure their antibodies, we need to understand this full spectrum really well. I mean, we still, in my opinion, have progress to make in terms of making the testing more intuitive. I mean, as at least in my clinic, I'm almost never the first person to send the testing. I need to rely on someone out in the community to kind of think about the diagnosis and understanding the testing well enough to order it. In particular, that lupus anticoagulant panel is a challenge, and it's typically confounded by anticoagulant medications. So one hopes there's a future where we understand the autoantigens well enough that we could use more traditional immunoassays. Yeah, well, I didn't talk about prothrombin in any detail here, but I think most of APS can be explained by anti-beta 2 and anti-prothrombin antibodies. These can both turn the lupus anticoagulant test positive. for example. But we need to make sure this is the full list. If we want to get to that future of focusing on immunoassays more than functional assays, we really need to make sure we understand this well. And then smarter outcomes for clinical trials. This has remained a barrier in the field. Thrombotic events are too common, but it's still a challenging landscape to jump into a clinical trial because you still worry you may not have enough events if you're using standard of care treatment. But I am seeing some cool things coming out of Europe right now about disease activity scoring. It looks like EULAR is going to release a first take on that maybe later this year. So yeah, something to keep an eye on. Can we develop a more holistic disease activity score that I'm sure will take a few iterations to get it perfected, but that's something I'm optimistic about seeing how that can push the field forward. And then if you want to do further reading, if you're kind of interested in microvascular APS, this is a paper from my team that just showed up online a week or two ago. So a very fresh paper here in circulation, but we went into some deep mechanisms that we think are contributing to the non-thrombotic aspects of vasculopathy that affects patients. So if you're interested in mechanisms of APS, go check out this paper. That's all I had for you. I hope you learned something and have a better idea of the future. And I'm not sure if there's going to be time for questions now or later, but I will be available.
For this informative and really enlightening and updated lecture. We ask you to hang on just for several minutes until we have our second talk delivered by Dr. Susan, and then we'll have the Q&A session. Thank you very much.